Welcome, everybody. Glad you could join us tonight. This is the January meeting of the nonprofit Plant-Based Nutrition Organization of Wisconsin, or PBNOW. I'm your host, Terry Lynch. The mission of our nonprofit group is to educate, inspire, and support each other on an evidence-backed, whole food, plant-based nutritional path for health and improved quality of life. Our group is open to everyone, those plant-based and those just curious about it, and it's meant to be a non-judgmental place for people to come get information, inspiration, and support. If you'd like more information about our group, our upcoming meeting dates, speakers, and other events, although there aren't many other events going on right now during COVID, and resources, you can go to our website, pbnow.org or pbnow.org. Just click on I think it's the information block there, and you'll go to registration, and then you can get our information and look at what's coming up. As we do each time, can I see with a show of hands or a thumbs up, how many of you are currently following a plant-based lifestyle? Get a little bit there. There come the thumbs up and the hands. Okay, so we've got, that's a good group. I'd say probably, that's maybe a little bit over a third of the group right now. Excellent. As we mentioned at the beginning of each meeting, the evidence of the benefits of plant-based nutrition in improving health and quality of life for people of all ages, as published in non-biased medical research, is quite striking. Whether it's improving health through increased energy, weight loss, preventing, slowing, stopping, or reversing problems like allergies, digestive problems, diabetes, heart disease, and early dementia, increasing our quality of life by helping us feel better quickly, strengthening our immune system, increasing our endurance, improving our athletic performance, speeding recovery from exercise, reducing our joint pain, clearing our thinking, or reducing the physical, emotional, and financial side effects of the illnesses, drugs, and procedures often recommended to treat the conditions that plant-based nutrition helps us avoid. The research shows our bodies do a wonderful job of healing themselves if we stop damaging them daily with poor nutrition and start giving them the nutrition they need to heal and function optimally. It's truly remarkable. Now, let me tell you what's in store for you tonight. You'll hear from three people. First, we're going to have an interview with Milwaukee physician, Dr. Rosalie Cassidy, and we'll hear some of her thoughts about the connection between plant-based nutrition and health. After Dr. Cassidy's interview, cook Amberly Childs will show us a plant-based cooking video and alert us to upcoming plant-based cooking classes. After Amberly, we'll hear from our featured speaker tonight, Milwaukee cardiologist, Dr. Joshua Liberman, about the best approach for determining your risk of heart attack. We should have 15 to 20 minutes left over at the end of that for Q&A for Dr. Liberman, so make sure you have your questions ready when we get there. Our program should end right at 7:30. And as a reminder, we have meetings every month, usually on the second Thursday of the month at 6 o'clock. Next month, we're going to hear from Texas vascular surgeon, Dr. Rizwan Bukhari, who gave us an excellent presentation in 2020. I think you really enjoy listening to him. In March, we'll hear from plant-based pioneer and icon, Dr. Michael Clapper. In April, we'll hear from Denver cardiologist, Dr. Andrew Freeman, who will give us his annual review of the year's most important plant-based research. And then in May, we'll hear from another plant-based icon, Dr. Caldwell Esselstyn. Once again, you can find out more information about our upcoming meetings on our website. And if you've registered on our website, you'll get email reminders of our events as they approach. Quick technical note, during the meeting, everyone but the speakers will be muted, and we ask you to stay that way so everybody can hear the speaker. And before we go to Dr. Cassidy, I just want to mention something. I just saw this the other day. I was looking, if none of you are aware of this, there's a there's a regular, either on YouTube or you can find these on podcasts. Physicians Committee for Responsible Medicine, or PCRM, has something called the Exam Room Podcast. And I'm not sure if they do this daily, but they're very good. They have physicians on, they have nutritionists on, they have people who have gone to a plant-based lifestyle, telling their stories. That type of thing is very well done. And about a week ago, I heard Dr. Dean Ornish, who is one of the people I really respect a lot, was being interviewed. And he was talking about two studies where they talk about diet and lifestyle as related to COVID. So he said one of the studies came out about a month or so ago and looked at almost 3,000 frontline healthcare workers in 6 countries. And as he said, these are people who get exposed to COVID-19 every day. In the study, those who were following a healthy plant-based lifestyle were 73% less likely to get moderate to severe illness, where those following a high animal protein, Atkins, paleo, or keto kind of diet were 400% more likely to develop moderate to severe disease if they get COVID. Likewise, at Harvard, in the Harvard Nurses and Physicians Health Study, where they have over 100,000 men and women who are physicians and nurses, those who made the positive diet and lifestyle changes were 43% less likely to get severe COVID. So as Dr. Ornish said, it's not just attempting to avoid the virus in the first place, but it's how your body interacts with it if you do get it, which in turn can be a direct function of your diet and lifestyle changes. So some good news for a change on COVID there. With that, let's get started. We'll begin by talking with Milwaukee physician, Dr. Rosalie Cassidy. Dr. Cassidy is a primary care physician. She's an MD and an MBA. She serves all age groups at Ascension's St. Joseph Hospital campus. Welcome, Dr. Cassidy.
Thank you for having me, Terry. It's exciting to be here.
Love having you. I'm going to ask a few questions. We'll start off with this one. Let me ask if you would tell us a little bit more about your background and your practice.
Sure. So I am originally from Canada, so I am here on a visa. I went to medical school in the Caribbean. It was honestly kind of a whim. I didn't know really what I wanted to do. So I went there. Then I was ended up based in Chicago area. So I matched for residency in Waterloo, Iowa. So I was there really the past 3 years. I just graduated last year from my medical residency. So I just passed my 1.5 years being out. So I'm a brand new physician, which is really exciting. And I'm definitely a Midwesterner now. I've come from the East Coast of Canada, but I've definitely, between Illinois, Iowa, and now I'm in Milwaukee, Wisconsin, have become a Midwesterner.
Well, you hit a spot there with me. My wife is from Waterloo, Iowa, so it's outstanding. You get a taste of it.
It's a fun little town. Ooh, and I just passed my boards of obesity medicine. I found out yesterday.
Wow, congratulations.
So I'm board certified in family medicine, board certified in obesity medicine, and next year I will write to be board certified in lifestyle medicine.
Oh, excellent. And are there certain things that you kind of lean towards? I mean, it sounds like already you're kind of leaning towards helping people with obesity, and in the lifestyle medicine would be lifestyle. And
yeah, definitely helping people with any sort of obesity related comorbidities, which I mean, at the end of the day ends up really being everything, but I really focus on people trying to lose weight with high blood pressure and with diabetes is kind of where my niche, and I would say my passion is. You know, I deal with everything on a day-to-day basis, but really helping people that are interested in really putting the work forward, because I mean, at the end of the day, you have to ask the patient, and some of them will choose to take a pill over putting effort in. And I mean, I do have to provide that service for them. But for the ones that are interested in listening, it's been really awesome. I love when I walk into the room and I see people going through my papers because I have pictures on the wall. I have little folders with information graphics that I've stolen from PCRM and Ornish and everybody. And I love when I walk in and the people are like, oh, am I allowed to take some of these? And I'm like, please help yourself. That's what it's there for.
Oh, that's outstanding. Talking about the plant-based nutrition, what kind of education have you had in plant-based nutrition? And I guess along with that, I'd ask what I've asked all the other doctors, what kind of education was there in medical school and residency?
Yeah. Medical school, nothing, absolutely zero. You learn about the micronutrients. You learn like what is vitamin D and how is it absorbed, which that doesn't talk to us about food. That doesn't mean anything. That doesn't compute. You can't talk to a patient or a person about absorption of certain micronutrients. You need to talk about the food and how everything kind of works together. Lynn chill. So nothing at all in medical school. And residency, the program itself did not incorporate any sort of nutrition. We were lucky enough in our clinic to have a health coach on staff. And she was not plant-based per se, but she definitely leaned towards that. So she was great because she could talk to patients about eating and sleep habits and smoking cessation and those sorts of things. So she was a great resource, and I sat and we chatted a lot. Like we were very close. But as far as the program itself, there was really nothing. So I had to reach out and do that learning for myself. So I did go to Dr. Barnard's clinic in DC for a month to follow those physicians around and meet with some of the people there. And then I just did really online study, like the nutrition certificates and things like that. So it falls on physicians to learn it themselves. We do not get teaching on that. And if we did, it probably would be wrong.
Well, what are your thoughts about whole food plant-based nutrition?
I love it. And it's actually finding it is what really enabled me to finish medical school, because I wasn't really sure it was something that I wanted to do. And I was trying to figure out how to marry my love for animals and medicine. And I actually got a life coach. And I don't know, through working through that, I found PCRM. And I was like, oh my gosh, like these are vegan doctors. This is exactly what I need to do. So originally, of course, I went vegan for the animals. That's my primary reasoning. But along the way, you find out like the huge health benefits that it has. And then just starting to dig deeper into that. I mean, you get down a rabbit hole and you're like, wow, this is like your cure-all. This is like how to make people healthy. This is how to avoid diabetes. This is how to have a healthy weight and just feel good, feel better. So I do believe it's something that is for everyone. And I wish it was something that we could, I mean, it's getting out there. It's definitely getting out there. People are starting to know, you can say vegan and people don't look at you quite so weird anymore.
Right.
So there's such a role for it. And especially in my practice being, the primary care provider, I'm like that first line, like I'm who people see first before anybody else. So making sure that we're really talking about prevention. And if we're talking about prevention, we're talking about food and stress and, sleeping well. And those are things that you have to bring up with people. It's so important.
Great. We've got about 3 minutes left here, but how have you incorporated plant-based nutrition in your practice?
So I am just hired basically as a family medicine physician. So I try and sneak it in wherever I can. Like I said, I have posters up in my room. I have lots of pamphlets and handouts. I will bring people back specifically to talk about diet and nutrition, which is kind of out of the norm, and there's billing difficulties with that. But yeah, I make it a point to bring people back to specifically talk about it if they're interested.
And I imagine, jumping back, you were talking about working with obesity. I imagine that moves over into diabetes and other obesity-related type of
Exactly.
things that
Yeah,
you're
I
working
see
with.
everything.
So, and because you have been, or you've been at ascension for a relatively short period of time now, so you probably haven't had a chance to see long-term results. But what effects have you seen the use of whole food plant-based nutrition among your patients who've embraced it?
Yeah. So I can't say that I've had anyone that's embraced it 100%, but I've definitely had success in getting people to realize that, like, I mean, as simple as realizing that McDonald's isn't good for you. I have patients that do not understand that. So just having them really realize that, oh, processed foods are not a good choice. And there's a variety of fruits and vegetables that they've never heard of. So sometimes it's as much as just sharing something they haven't tried before. So for the people that have at least started eating more vegetables for one thing in their life, there's positive, like they're like, oh, this was good. I really liked Brussels sprouts. I'd never tried them before. So for the people that do make an effort and try, they like it and they feel better. And I'm taking people off their blood pressure medications. I had a man whose blood pressure was through the roof. And I was like, I'm going to have to start you on 2 different blood pressure medications. And he was eating McDonald's every single day. He came back in 2 weeks, didn't touch McDonald's, and I didn't have to start the medication. His blood pressure was perfect.
You're kidding. In 2 weeks. Yeah, it's just amazing how quickly these changes can make a positive difference for people. Is there anything else you'd like to add?
I don't think so. I'm just really glad that there is a plant-based group within this area. That was one of the things that I was nervous about coming to a new place. So I'm really glad that you found me, I believe, or somebody in here pointed me your way.
Yep,
So I'm really excited about that.
David.
I do take new patients. I know I'm kind of out west, not in the greatest location, but anyone is welcome to come see me, ask me questions. I'm free. I can give out my email, whatever. So
yeah, I was going to ask you to do that. If you could pop your email in the chat box, that would be great.
There we go. All right. Thank you.
Great. Well, thanks, Rosalie.
We're happy to have you in the Ascension system.
Yay. We still have to meet face to face someday, Dr. Liberman.
Absolutely.
Oh, that's great. So hopefully we'll have you back again too.
Absolutely. I'll be here.
Thanks, Rosalie. Our next speaker is plant-based cook that most of you know. She's the founder and operator of the Milwaukee company Plant Joy, through which she teaches plant-based cooking classes and offers an ever-expanding menu of pickup or home-delivered plant-based meals, making it easy for people to incorporate plant-based nutrition into their daily lives in a delicious manner. You can find more specific information about her and Plant Joy at plantjoy.net. She was trained and certified as a plant-based cooking instructor in the Food for Life program run by Dr. Barnard's Physicians Committee for Responsible Medicine that Dr. Cassidy just mentioned. There are a number of Food for Life certified instructors in the country, but many areas of the country don't have the luxury of having one nearby. We not only have one here in Milwaukee, but she is excellent. To share with us a cooking video and alert us to upcoming plant-based cooking classes is plant-based cook and cooking instructor Amberly Childs. Amberly?
Hi, Terry. Hello, everyone. Happy January. We got through another year. Good to be here. So I was completely, I'm not paid to do this, but I do want to give a small shameless little plug. I'm a patient of Dr. Cassidy's. And I've been seeing her probably for maybe 6 months. And I can say how I found Dr. Cassidy was I wanted to specifically find a plant-based doctor or provider. I've had cancer, I've had 8 surgeries, I've had all kinds of doctors and specialty providers that have cared for me over the last decade. But now that I'm not in that care anymore, I really wanted to settle down with a primary doc. And I just didn't have one since I had been in the care of so many different physicians. And so I was really looking to start up care with a new primary. And it was really important to me one, someone who would understand my adoption of a plant-based diet and support that, but then also who could be able to support me coming out of cancer and all the, the things that I've gone through. And so Dr. Cassidy was, for where her hospital was located, isn't necessarily somewhere that I was like, oh yeah, this is in my loop, but I've made it be in my loop, and it's been a real pleasure. And I tell you, there was nothing more exciting than being in her office and finding the power plate from PCRM. Like, I totally nerded out. I was taking pictures, I was posting them on social media, and it's really exciting to be. I had never been in a doctor's office besides the oncologist that helped me get through my cancer that supported a plant-based regimen and had information there. And we see Dr. Liberman here monthly. And, so we have seen a few others, but to find somebody in Milwaukee is just mind-blowing. It's so exciting. And it's proof that the movement is happening. So we all need to keep doing what we're doing and keep sharing information, because more patients are having opportunity to interface with providers who believe in the power of plant-based medicine. So the other thing that I want to challenge the providers on this call to do is, I think you all have a huge responsibility to share with other medical providers the power of plant-based medicine as well. I know you all have a lot on your plate and you get inundated with day-to-day stuff as we do, but there's so many doctors, as we know, that don't know the power. And so I think that we all can continue to share. So off my soapbox. So Terry and I were talking a little bit about doing something different today. And so one of the things we had recorded, I had recorded with PCRM a small cooking video, and I thought it would be fun to play that instead of you all listening to me talk.
And I really hope you try and recreate them at home and upcoming. So a little bit about me before we get started. I am a Food for Life instructor, as I said. I'm also a 10-year cancer survivor. I had breast cancer in my 30s. It was very aggressive, and I had the wonderful opportunity to be knowledgeable and work with an integrative oncologist, and I used food as medicine throughout my entire treatment. And now I use food as medicine to help keep my body optimal, living healthy, and to prevent recurrence of disease. So however you are using plant-based foods, whether it's to lower your weight, whether it's to prevent heart disease, whether it's to prevent cancer, food is medicine, and know that it can be wonderful, it can be delicious, and I'm going to show you two great recipes right now. So the first one we're going to, it are wonderful. Look how nice it is.
Sorry, we're only doing one of the recipes.
Is a penne. We're using kale, tomatoes, and clamato olives. So once again, I've got my saute pan going here. We're doing a no oil saute. I've got diced onions that are gonna go ahead. You hear that? Ooh la la, it sounds like we're cooking, right? Because we are. My husband said this so long ago, and I love it. He said, anytime we have people over, you should just saute onions before they come over, because the whole house will just smell like you've been cooking all day long. So there, take that little free tip and treat your company, or you know what, treat your spouse or your partner or your kids or whomever is in your home. Treat them, because unfortunately we're not having a lot of gatherings right now because of COVID-19, but we will, I know this. So I'm gonna let this go. I had a little bit of onion skin here, which is what I'm peeling out. So I've got that onion sauteing on here. Once again, I've got my vegetable broth or water right by, and as this starts to caramelize and stick down onto the pan, I'll be able to add my water. And what that water or vegetable broth will do is it will deglaze the bottom of that pan, and all of that sticky stuff, that browning, that caramelization is going to be lifted up, and it then will be added into our flavor profile. All right, so I'm turning this baby up to high. Ideally, we want to cook and let these flavors marry together for about 15 minutes. So I've got the onions going. The second ingredient we're putting in there is roasted tomatoes. So these are diced tomatoes. This is a real easy workaround here. I could have chopped up my tomato, but I went ahead and cut the corner and bought it in the can. One, they're organic. 2, it's a BPA-free lining, which makes me feel comfortable. And then 3, they're fire roasted, so they get this extra caramelization on there that works super well with what we got going on. We have some fresh chopped parsley that I'm going to put on at the end. We've got some sliced Clamato olives that we're going to put in there as well. And then the last ingredient is our kale. And I went ahead and chopped up some kale, and I'm just super excited to share this with you. The kale and the parsley came from my garden, and if you don't know, I live in Milwaukee, Wisconsin. We have had snow already, and kale is still growing. So while these are continuing to saute, I'm going to show you really quickly with my knife the best way to cut a piece of kale. Okay, see this? You take your knife and you come down, and you just slightly turn it. 1, 2, 3, and then the kale comes off. Obviously, we'd be catching it. And then you can take your kale. I like to then put it in water. From there, you can then pull it out of the water. And when you're pulling it out of the water, what's happening is the dirt and the dirties that's from growing are coming off of that. So the caramelization, you can see here, I got a little bit of browning that's starting to happen. How about that? Looking really good. Now what we're going to do is we're going to add in the tomatoes. The recipe calls for 28 ounces of diced tomatoes. Remember, I went with a roasted tomato. Yum, 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 yum. We're going to mix these in and just let it to continue to cook. I've got it on a medium-high temperature right now, stirring it all together, and then I'm going to add in the kale. If you have family at your house that are like, we don't do kale, cut it really small. I cut this into small little ribbons, small little pieces, because that kale is going to cook down. And that is going to make it easier to digest. It is going to make it easier, visually it's going to be a little bit nicer, especially if you've got people at your house that maybe aren't kale lovers yet. If you have people who are concerned about any ingredient, whether it be greens or anything, chop it up a little bit smaller, and I bet you'll find you won't notice it or they'll like it all together. So, finishing up here, I've got my pasta. This is the corn and brown rice rigatoni noodle. I just cooked that. I'm going to add this in here and put some of my parsley in here. While this is continuing to cook, I'm going to go ahead and add in my olives. I left in a little bit of the olive juice because olives are really salty, and that's what makes part of this dish fantastic. And so that salt works really well, and the brine that those olives are in is really yummy. So I just took a little bit of that. We also are getting the juice that comes from, you can see we're looking good so far, the juice that comes from the tomatoes is really nice in here. So right now I'm going to go ahead and just slowly add in a little bit of the pasta, and I'm going to keep stirring. The pasta is already cooked and it's warm, but we're just giving it a little bit more heat right now. It's so pretty, the colors. I mean, this is just a dish for you to really get in there and enjoy. All right, I'm turning this off. I thought I was turning it off. How about that? I'm going to dump it all into one bowl. I'm going to give it a final mix. I'm going to top it off with some nutritional yeast. Could be for a vegan Parmesan cheese, but I'm a nutritional yeast fan. My kids love it. My household loves it. We use it all the time, and it gives a nice cheesy flavor to anything. We'll top it off with a little extra parsley. Manja. Look at that deliciousness. We've got
All right. Are you hungry yet?
Hungry now. Oh, that's excellent, Emily. And we're going to go to Josh here in just a second. But can you give us an update on upcoming classes?
Absolutely. So we've got a couple cooking classes coming up. The next one is going to be January 27th on a Thursday. It's through the West Dallas Recreation Department, and they just built a brand new facility. It's got a huge kitchen, a daycare, basketball courts. It's a brand new facility. It's wonderful. This is a day class, and it's a kickstart class. So it's basically an introduction to plant-based eating. It comes along with a Dr. Neil Barnard video. So there is an educational component that comes with it. We'll watch a small video. I'm going to cook 3 different dishes, and then we will all eat all of those. So that's going to take place in January. February, the end of the month, we have a new curriculum that just came out last year from Dr. Barnard's book. And so it's about women and menopause, hot flashes, kind of irregularity as women start to move later into life. And what we're finding is a lot of these hormonal changes, the symptoms that come from some of these things can be exacerbated by the standard American diet. And the best thing is they can be kind of reined back in with eating more of a plant-based diet and more organic, non-GMO tofu, soy foods. So we're going to really dive into that, and we're going to dive into a lot of soy food in that February class. So those are the next 2 we have coming up. So anyways, I'll end it there. We did have the recipe on the screen. I'll share the recipe with Terry in electronic format. You know what, I might be able to attach it here, but either way, I'll make sure that
Sure.
everybody has a copy of the recipe that you saw demoed, and it's super healthy, super yummy, and it is from PCRM's Cancer Project curriculum. That is one of their recipes. So it's really low in fat, really good, high in fiber. So thank you all so much. Have a nice rest of your winter, and we'll see you next time.
All right, thanks, Amberly. And I'd mentioned too that I think, and Amberly, you can confirm this, I think PCRM did a research report on menopause and diet.
Yes.
That's within, I don't know if it was the last year.
Yes.
Something like that. It was just very recent, and it was pretty amazing, the benefits of eating plant-based or diet and lifestyle when you're going through menopause, as you mentioned. And once again, these classes are posted on plantjoy.net, right?
Correct. Classes are at plantjoy.net. You would register through the West Dallas Recreation Center, but when you go to my website, I have a link there and all the information about the class, the recipes we'll be cooking, etc. So plantjoy.net is where you can find more information about those classes.
All right. Thanks a lot, Emily.
You're welcome. Thanks for having me, Terry.
Our featured speaker tonight is also familiar to many of you. He is our PB Now Medical Director. Fellowship-trained cardiologist practicing cardiology at Ascension Columbia St. Mary's here in Milwaukee. He is past president and current trustee of the Wisconsin chapter of the American College of Cardiology and is a member of the American College of Cardiology's National Prevention Work Group, whose membership includes physicians such as Dr. Dean Ornish, Dr. Caldwell Esselstyn, and Dr. Neil Barnard. He's an advocate for the use of plant-based nutrition to help improve heart health, general health, and quality of life, and has seen the benefits of plant-based nutrition both in his personal life and that of his patients. We're fortunate to have him practicing here in Milwaukee and as our PB Now Medical Director. I'm happy to welcome Dr. Joshua Liberman. Dr. Liberman.
Thanks, Terry. Appreciate it. Everybody, thanks for coming. We have a nice big crowd here today to hear and meet Dr. Cassidy and to listen from Amberly. I'm sure that's it's just great. It's an increasing community of plant-based advisors, providers, supporters. It's just really wonderful, and it's just nice to see this growing. You started this, Terry, and you should obviously take a lot of credit and feel really good about it, but it's just wonderful to see what it's grown into and the connections that people are able to make as a result of this. I just love seeing in the chat group, people now thinking about reaching out to Dr. Cassidy, looking for help, looking for a new primary care doctor. And it's hard because there's a lot of people who, this is really, I guess you could almost call it like a consumer driven field, in that, individual people are trying to advocate for themselves and seek out resources to help them. It's unfortunate that the medical community is not ahead of them reaching back and pulling them along. It's people pulling the medical community along. But one way or another, we're moving forward, which is great. Many of you people on this call, are familiar with me and my practice and how I usually like to talk about some plant-based stuff. But today we're doing something different, actually. And so I'm not really going to talk about anything plant-based. Maybe you're tired of hearing me, and maybe that's why more people are tuning in tonight, because they're tired of hearing me talk about plant-based and they want to hear something else. But tonight I'm just going to talk about something that's general cardiology kind of stuff, prevention of heart attacks, and trying to assess, your risk of having a heart attack. And some people on this call may learn something. Some people may be interested in pursuing something and getting more information. Feel free to contact me either through the chat box or through the PB Now organization, or email, or my chart, or any of these things. But without much further ado, I think I will start sharing my screen.
Yep, here we go.
Okay, does everybody see that slideshow?
Yes.
Okay, let me, I need to minimize the video. Okay, all right, so the topic is, what's the best way to determine, your risk of having heart disease? And a different way of phrasing this would be, do we have some kind of test? Do we have a picture that would be worth 1,000 words? Okay, hold on. That doesn't want to advance. Oh, there we go. I guess I got to do this to advance it. All right. So one of the reasons that I love being a heart doctor is because because heart disease touches so many different lives. Heart disease is the #1 killer of people in this country, and it's just it so outweighs all other causes of death. So a lot of people out there are under the misunderstanding that that maybe breast cancer is the biggest risk that they face, or lung cancer, or stroke, or any of these other terrible things. But in reality, if you added up all the different kinds of cancers combined, it still wouldn't add up to the number of deaths that are caused by heart disease. And that's, I want to highlight, that's true for women as well. A lot of women in surveys, certainly the research shows that a lot of women out there believe that breast cancer is their #1 risk of death. And that's simply not true. Breast cancer is obviously very common, unfortunately, but death from breast cancer is much more rare. And most women who are diagnosed with breast cancer will die from heart disease. When I first put this slide in a couple of years ago, that seemed like a much further time away from now, but 2035 is rapidly approaching, I think. By then, almost half of the US population is expected to have some form of cardiovascular disease. For I don't know, about 40 years, we had been doing actually a really good job of bringing down the rate of death of heart disease. We've saw basically a 50-year steady decline, mostly because of decreasing rates of smoking and tobacco abuse. But unfortunately, in about 2010, we hit a plateau, and it's actually deaths from heart disease are unfortunately going up once more. And so if you look back over the course of the last 50 years, we've made tremendous progress with medications and procedures and support devices and all sorts of fancy stuff. I mean, just the fanciest, most advanced medical technology. And we can save a lot of lives, and we can prevent a lot of people from dying. But unfortunately, despite all these advances, heart disease continues to be the leading cause of death. And one of my mentors, Dr. Kim Williams, who has spoken to this group before, kind of likens it to, turning on a faucet at a sink and letting it run until it overflows the sink. And most of our technologies and medications and procedures are designed to mop up the floor, right? To clean the water off the floor and to keep the floor dry. But of course, the most effective way to prevent deaths from heart disease would be to turn off the faucet. And that's just what we're just not doing that. Yeah, so I mean, we've just made a lot of advances, as I said, but we've really not made a lot of great progress in preventing heart disease, or what we call coronary artery disease. And unfortunately, in 50% of patients, the initial manifestation of heart disease is a heart attack or death, right? And that's just not acceptable, right? If the first you know that you have heart disease is when you're rolling into the ER on a gurney and being told you're having a heart attack, that's just a failure of the medical system, I think. So one possible solution is that we're just more aggressive with treating risk factors, right? You just put everybody in medications, right? You just say, okay, anybody with even a glimmer of high blood pressure, put them on medications. Anybody with a cholesterol panel that just looks askance to you, put them on cholesterol medication, and just be really, really aggressive with treating risk factors. The problem with that approach is that not everybody who's destined to have a heart attack has obvious risk factors, right? A lot of people out there actually have completely normal cholesterol. They don't have high blood pressure. They're not, an obese male, pack-a-day smoking diabetic guy sitting on, a couch all day that you can just look at and say, oh yeah, you're just a ticking time bomb. There's a lot of people out there that don't have obvious risk factors. 50% of heart attacks and strokes occurred, in individuals who didn't even have elevated cholesterol by, by a lot of the different metrics and ways we measure them. And, certainly when this study came out, admittedly over a decade ago, about 50% of patients with the first heart attack had bad cholesterol levels under 100. And frankly, that's what our goal is for most patients. So, if we're still having a significant amount of heart attacks in those patients, then we're definitely missing something. So what we need to do is find a better way of identifying people at risk of having heart attack. And so if maybe people want to just try to make sure that they're on mute, that'd be great.
Yeah, I'll try to find that, Josh, and turn it off.
Okay, no problem. Kimberly Battle Miller, maybe? Okay, so just, trying to give some examples, so here's an example of a 49-year-old female, so she has a very bad family history of heart disease. Her dad had a heart attack and then bypass surgery at a young age. This is not a real picture, but I guess we don't really need to have pictures, but she exercises daily, she eats, quote unquote healthy, her blood pressure is good, and her bad cholesterol LDL is 137. So you might look at this and even a really good primary care doctor might look at this and say, there's not much we have to do here. You don't have a lot of risk factors. You do have that family history, but maybe you got your mom's history, not your dad's history. So the question is, what should a doctor do now? What should a provider do now? What would you do now? Here's a different woman, slightly older, no family history, a little bit overweight. A1C, that's a measure of diabetes, so she's borderline diabetic. Again, her cholesterol numbers, not terrible. What do you do about this? Do you put her on diabetes medication? Well, she's not technically diabetic yet. Do you put her on cholesterol medication? I mean, again, her numbers aren't that terrible. She doesn't have a family history, and her blood pressure is okay. So you just tell her to eat healthy, eat a plant-based diet, and exercise. I mean, that's certainly one approach. Absolutely. And then there's this other guy who's, his cholesterol panel looks fine. His blood pressure is a little bit high, but he's a smoker. So fine, at least we know what to do with him. We can say, okay, you need to quit smoking. But what else? Again, the key is like these patients all have risk. And the problem is, what do we do about this? We have a feeling that they're at risk. They're not at high risk. They don't have a lot of uncontrolled risk factors. They're definitely not at low risk. None of these patients are at low risk. The problem is that they're all in that intermediate range, and we don't really know what to do with patients in this intermediate range. So, hopefully you know where I'm going, and the answer to the first question is, yeah, I mean, these patients probably need a further evaluation, but what's the next evaluation? A lot of patients come to me saying, doc, I'm worried about my family history. Don't I need a stress test? And, what I'm hopefully going to teach you is that a stress test is really not the best way for assessing somebody's risk. Oops, sorry, the animation was all screwed up here. All right, so the status quo is there's a bunch of different things we could do to try to assess somebody's risk. We can do blood tests, right? But the problem is, I already told you that, you know, these blood tests aren't necessarily all reliable. And you can do advanced tests like an NMR particle analysis, or getting an apolipoprotein B, or a high sensitivity CRP, which is a marker of inflammation, right? There's going to be other tests too. I mean, I could list a dozen tests up here that that some are marketed to be really predictive, some have data to support it, and some aren't. Some are just marketed as such and really don't have the data. We can do some stress testing, right? We could do just a plain old treadmill test when you're hooked up to an EKG monitor. We could do a nuclear stress test. We can do an echo-based stress test that's an ultrasound. I mean, we can do all sorts of different kinds of things. We can do pictures of your neck to see the carotid ultrasounds. We can do a special CAT scan of the blood vessels of your heart. And we could obviously also do a true heart catheterization angiogram procedure, but that's an invasive procedure. And, you know, we certainly don't want to be doing that just for, you know, to help us risk stratify people. So a lot of people, as I said, say, well, gee, doc, don't I just need a stress test? Won't that clear me? And the problem is that stress testing will really only identify patients with such advanced blockages, such advanced plaque, that there's actually a decrease in blood flow to the heart muscle. And of course, that's important to know. But the problem is that that's not the only way we can find heart disease. Because what if you have like a 30% blockage or a 20% blockage, right? That's not going to be enough to actually decrease blood flow to the heart muscle. Even if you're running a marathon, you're going to get just as much blood flow down to your heart as you need with a 30% blockage or a 40% blockage. Really, the only blockages that actually decrease blood flow during exertion specifically would be something that's worse than 60%, which means that any stress test out there is not going to find a blockage that's 50%, 55%, 40, 30, 20%, right? But it's not like those blockages don't matter. They do matter. It's just stress tests aren't going to be able to find them. And so you could pass a stress test with a 50 or 55% blockage, and you could take away from that you're fine, that there's nothing to worry about, right? And your doctor could take away from that you're fine, that there's nothing to worry about, and just go on living your life. And unfortunately, there really, you know, obviously still is something to worry about. And so it turns out that it's not just the degree of the blockage of a specific blockage, the severity of a single blockage that's the most important predictor of death. It's really the extent of how much plaque you have. If you have, you know, 10, 30% blockages, that's going to be a lot worse for you than 180% blockage, right? 10, 30% blockages are worse. And so it's the extent of plaque. It's the extent of blockage rather than the severity of a single blockage. That's the most important. And plenty of studies have shown this, plenty of, frankly, autopsy studies have shown this, that blockages that cause heart attacks often come from start as a 30% or a 40% or 20% that's what we call a vulnerable plaque or a juvenile plaque or an immature plaque that is much more likely to rupture and cause a heart attack than something that's been there, you know, for decades and is growing slowly over time. So what I, you know, say is, you know, what if there was a test that allowed for detection and quantification of the amount of plaque, and which was a really good measurement of the extent of plaque and actually could also predict the severity of plaque, right? What if there was a magical test just like this? And the answer is there is one. It's called a calcium score, or, you know, some institutions call it a heart scan. And what actually is it is that it's a CAT scan. It's a very low radiation CAT scan. So basically it's a fancy X-ray that is performed in a special way where the pictures are matched to the heartbeat. So because of course the heart is moving, and it's hard to, if anybody out there is a photographer, it's, you know, it can be hard to take a picture of a moving object. So you obviously have to adjust the settings of your camera to do that. Well, that's what we're doing with this too. We're adjusting the settings so that we're taking pictures in concert with the heartbeat. There's no injections, there's no contrast, there's no need for an IV. It doesn't need any special preparation. You don't have to be fasting or, you know, not taking your medications or anything like that. And basically this day and age, it can be performed on basically any CAT scan machine in any hospital, you know, anywhere. And I don't know if you can see my cursor, but what I'm trying to show you is On
Yes,
the left
yes, we
side,
can.
can you, if you see me moving it?
Yep.
Good. So on the left side of the screen is a CAT scan picture of a heart. This is called the aorta in the middle here. This is the big blood vessel that leaves the heart and delivers blood to the rest of the body. And this here is the left main, and then what we call the left anterior descending coronary artery. That's what it would look like on a CAT scan. And it should be this dull gray color that is the color of basically of tissue or even blood in the body with no IV contrast. On the other hand, what we can see is this is what calcium looks like, right? And just like here, it looks like bone, right? This is your vertebra. This is your spine, one of your spinal bones, one of your vertebrae. And CAT scans and X-rays are really good at seeing bones. That's why we take them. You know, if you break your arm or you think you broke your arm, you're going to get an X-ray of it because X-rays are really good at seeing calcium. They're really good at seeing bone. And basically what's happening is that the plaque over time is hardening and solidifying and turning into rock. That rock is calcium, the same as we have in bones. And we can see that on an X-ray. So this patient has a lot of plaque in the big blood vessel down the front wall of your heart. And this area here is what we call the widowmaker, or we don't call it, but that's what's known as the widowmaker. And you know, you get, when you get this test, you get a score from 0 to some higher number. There's no upper number. There's no limit. It's not like 0 to 100 or anything like that. I have plenty of patients with scores in the zeros and in the low teens. I have patients in the 900s and thousands, and I have patients in the 3000s as well. And it does matter, you know, how old you are when you get this. If you're older, say, than 75, you're likely to have some hardening of the arteries. And so, you know, a score of, say, for example, 100 in a 75-year-old person means a lot different than a score of 100, the same score, but in a 35-year-old, right? So you know, we take into account patients' age, their sex, and we compare it to one of the many available databases that are out there. And we give you an idea of what your risk level is based on what we know, based on the robust amount of evidence we have about, you know, and data we have about these tests. I have some patients that say, well, is it accurate? I mean, can it be mistaken? And basically it's 100% specific, which means that if you have some, you have plaque. There's no question. I mean, it can't be wrong. It can't be falsified. You can't bargain with it. You can't say, well, what if I do it again? If, you know, what if I really, you know, what if I go plant-based for the next month and then check it again? Yeah, it doesn't matter. If you have calcium in the walls of your arteries of your heart, you have plaque. You have what we call atherosclerosis. And we know that the degree, the higher the number, the more likely it is that you have a severe blockage. And this is based on, as I said, a lot of different studies. But again, the total score really gives you a burden of how much plaque you have. And it's that's more important than knowing you have a 90% blockage versus 60% blockage versus a 30% blockage. And if you compare it to doing an angiogram, as I said, it correlates very well with finding significant plaque or significant blockages on an angiogram. And in fact, there was this conference that, you know, it's now 20 years ago. So it's not like this is a new test. And you may say, well, how come my doctor didn't, you know, recommend it? Or how come my insurance company doesn't recommend you? Well, all right, that's a conversation for a different time. I'm just talking about the test itself right now. But the bottom line is, you know, for 20 years, we've known it's been really good. And 20 years ago, this group of doctors that created what was called the Bethesda Conference, they all got together to look at all the different kind of tests that are out there. And they came out with a recommendation then, 20 years ago almost, that said that this is the most accurate available method for the early detection of plaque. And so, you know, the question is, well, you know, how prognostic is it? Is it really actually prognostic? And again, the answer is yes, from a lot of different studies. It is the single best predictor of heart attack risk available today. And this is, again, much, you know, studies spanning the last 20 years and even up till now. A number of publications put in very prominent journals, from, you know, Journal of the American Medical Association to American College of Cardiology to, you know, Radiology and New England Journal, and all these different, you know, really, really prestigious journals have shown that it is significantly beneficial in terms of defining somebody's prognosis in large in many different kinds and groups of people. all ranges of risk across all ethnicities, all different kinds of populations, everything. And it works, it improves and it works over and above historical and known traditional risk factors, such as, cholesterol, not to say these are useless, but this is just better, especially when added on top of, blood pressure, sugar levels, carotid ultrasound, what's called the ABI, which is a measure to see if you have plaque in your legs, and all sorts of different tests. And so when they've done research on this, they've shown that any kind of scoring system or predictive algorithm or any of these things that doctors come up with, like I don't know if some of you have ever heard of the Framingham score or things like that. Any of these equations that your doctor can plug your information into and spit out a number of how likely it is that you might have, heart disease, a calcium score, when added on top of that, always makes it better. And, the higher your score, the worse your prognosis, unfortunately. And if you have a score in the highest quartile, you have a significantly increased risk of a cardiac event, 10-fold higher if you're a man in the highest quartile. So again, if you divided all scores into 4 groups, the highest quartile is the highest 25%. And then, so this is just, saying basically the same thing in a pictorial format with the different colors. So the dark blue is a calcium, that's coronary artery calcium, CAC, calcium score of 0. They have the lowest risk, regardless of age group and regardless of whether we're looking at coronary heart disease or cardiovascular disease, which includes stroke, or even all-cause mortality, which is like, dying from any cause, whether it's cancer or heart disease or anything. And you can see it's a linear kind of relationship where the lowest score to the medium score to the highest score, no matter what age you are, no matter what we're looking at, the risk goes up as your score goes up. And this is exactly what we would want to see from a prognostic test. And again, risk of death and all different kinds of bad things went up as the score went up. So what do we need from a predictive test? Well, the main thing, and this is what I was getting at earlier with those pretend patient cases of a bunch of intermediate risk patients, we need to know what to do with an intermediate risk patient, right? Because guess what? With a low risk patient, right? Somebody who walks into my office and says, "Doc, I'm already plant-based. I exercise 30 minutes a day. I don't have any family history. I've never smoked in my life. My cholesterol profile is perfect. My blood pressure is perfect. All these things are perfect. What should I be worried about?" And I'll say, listen, this person is low risk. Now, is it going to hurt them to get a calcium score? Sure, no, it won't hurt them. But the point is that we know what to do with low risk patients. We just tell them, keep doing what you're doing, right? Keep eating healthy, keep exercising, keep doing all the right things in your lifestyle. So we don't really need a lot of help with low risk patients. And on the other hand, to be honest, we don't really need a lot of help with high risk patients either. We know what to do with them. I'm not saying when I say we don't need any help, like we're going to do something. We just don't need help. Like when a patient comes to me, clearly high risk, right? They come in with a pack of cigarettes in their shirt pocket. Their sugars are out of control. They're sweating just as they sit in your seat or, something like that. Like I don't need a test to tell me that person's high risk and what we should be doing with them, right? So there's a lot of things we know what to do, and that's not the issue. It's everyone in between that we have an issue with, right? It's the patients that come and say, I have a really bad family history, but everything else is perfect. What do I do with that, right? These are the patients that we need help with. And that's what we need a predictive test to be able to help with. It's called reclassification. We need to be able to reclassify the intermediate risk patients into low risk. Hopefully, that's my goal, is to be able to tell patients that they're low risk. Or if they're high risk, to tell them, guess what, ma'am, guess what, sir, you are high risk and we really need to take this seriously. So reclassification is the terminology that we doctors use to try to tell us if a predictive test is useful. It's useful if it helps us reclassify patients. And certainly in one recent study that just came out last year, no, it was a small study, only, less than 400 patients. They were in this intermediate category. 31% of patients in this group were able to be reclassified into a low risk group because they had a calcium score of 0. On the other hand, 40% in this intermediate risk category had very high scores and they were reclassified into a high risk group. So right there, we took 70% of patients in that intermediate risk category and were able to give them a more honest, accurate assessment of their risk level. And that is huge. That's what we need to be doing to prevent heart attacks. And, lots of other studies show that, it depends on the size of the study, depends on the population it's done, but basically intermediate risk patients, 10 to 25% could really be found out to be low risk, and 20 to 30% are shifted to high risk. And again, my goal is not to make people high risk. My goal is to find out if they are high risk so that we can start enacting an aggressive risk reduction strategy. And it turns out that certainly in this study that came out, a while back, the patients, you could say, well, gee, is it accurate? If they're reclassified into high risk, is it really true? And the answer was, yes, it really was really true. These patients really did have a high event rate. And on the other hand, patients who were reclassified into a low risk group because of the calcium score truly were low risk. They had a very low risk of heart attack over the next 5 years. So again, that was a lot of people that you just saved a lot of grief from. Like these are people that come to see me and they say, Doc, I'm really worried. My dad had a heart attack at 55. His dad had a heart attack at 55 and I'm 54. What do I do? And for these patients, if we find out that their calcium score is 0, then we can tell them very safely that their risk is profoundly low. And so even, the most recent cholesterol guideline updates recommended in intermediate risk patients to be using calcium score to help us determine, who would benefit from treatment and who would benefit from simply lifestyle advice. So what does it mean if you're reclassified into a low risk group because of a calcium score? It means you won the lottery. Certainly depending on your age. Now, if you're 35, odds are you're even if you have some plaque, it may not be hardened plaque. And so you're not out of the woods. You didn't really win the lottery at age 35. But I got to be honest, if you're 60, 65, 70, and you have a 0 calcium score, you won the lottery. You are not going to die from heart disease. Heart disease is not going to be the thing that takes you out of this world. And what we call this is the power of 0, right? This is the terminology we give, the power of 0. Sounds very fancy. But what it means is that dozens and dozens of well-done large studies have shown over the last 20 years that patients with a calcium score of 0 have an extremely low mortality rate. These are the healthiest people out there. It's about 1% risk over the next 10 years, which means that person's risk of heart attack is on the order of 0.1% each year. And there's other studies that say that their risk of dying from any cause is only about 3% in the next 15 years after they get this kind of a scan, right? A 0 score is tremendously prognostic for a favorable outcome. Very low rate of death, as I said, 0.1, 0.4% in many, many studies over the last 20 years and up to 12 years out. There's no other test. There's no other test in any other field of medicine, kidney medicine, brain, lung medicine, anything. There's no other test that can give such a favorable prognosis that far out. And this is, this was a big one, again, a long time ago, over 10 years ago, a meta-analysis, oh, I spelled it wrong, of greater than 64,000 patients. Only of the 64,000, about 25,000 had a 0 score. Only 146 of those 26,000 patients had a cardiovascular event in the next, monitored time period of about 5 years. 0.5% total in the next 5 years. That is an incredibly low amount. And then, if you, even in older patients, which, I think there's a couple on this call, in the 75 to 84-year-old age group, over 8.5-year follow-up, those with a calcium score of 0 had a very, very low event rate over the next 10 years, right? 1.8% versus 21% if you were 75 years or older and had a calcium score of greater than 100, right? That's a huge difference. And again, no matter what way you look at it, patients who have 0 scores do extremely well and had a survival rate in this study of 44,000 patients of 98% out to almost 6 years. Again, not a lot of other tests, no other tests, frankly, can give you this kind of a favorable prognosis. The one Achilles heel, and I really wouldn't call it Achilles heel, is that if you have uncontrolled diabetes, again, many people on this Zoom call and involved in this group aren't the patients that we're talking about here. But uncontrolled diabetes can cause rapid growth of plaque and rupture of soft plaque. So even if you have a score of 0, your risk is unfortunately still high, even with a score of 0. But patients with a calcium score of 0 experience low rates of important non-heart related diseases, including kidney disease, dementia, cancer. So a score of 0, as I said, is really a winning lottery ticket almost across the spectrum. Again, depending a little bit on age. And the most recent guidelines that I was referring to earlier say that if your score is 0, even if you have some other risk factors, it's reasonable to not start statin therapy. Even if your cholesterol is high, it's reasonable to not start statin therapy because your risk is overall so low. And these patients really can be effectively treated with lifestyle changes alone. So as I said, it's basically a winning lottery ticket for most people out there. Now, the problem is that not everybody's going to get a 0 score, right? And so what does it mean if you're reclassified into a higher risk group? Well, unfortunately, it does mean that your risk of heart attack is higher. Now, it does not mean that you're destined to have a heart attack, right? And there certainly are lifestyle things like a plant-based diet, like exercise, and there are medications, of course, that can lower your risk. And I certainly am an advocate for an all of the above approach. I recommend all of the above: plant-based diet, exercise, and for these patients in a high-risk group, medication as well. Unfortunately, score greater than 100, again, it depends a little bit on age, is associated with an event rate of greater than 7.5%. Compare that to 1%, right? And this is the level at which the guidelines really recommend initiating a statin, for example. And as I said, if your score is greater than 300, you have a much higher risk. And if your score is greater than 400, an even higher risk, a 10-year hard event rate of 13.5%. So, 13, 14-fold higher than if you had a 0 score. And then, again, this is just basically saying the exact same thing, which is that as your score goes up, your risk goes up for different things. And the red bar is people with the higher scores. And this is their event rate in different studies. Yeah, so kind of repetitive, but overall. And then if you're reclassified into a very high risk group, like, so if your score is greater than 1,000, unfortunately, these patients had a 25% annual event rate for heart attacks and deaths. And so these are the patients that, we really work very hard, very aggressively with to lower their risk. These are the patients that I really try to, hammer home the importance of a plant-based diet, routine, regular exercise, and intensive medical therapy for these patients because the risk is so high. And this is just a different pictorial way of saying, what your survival is by score. And so this top line here is a score of 0. They had the best survival. And as the score goes up and up and up to 1,000, survival over 10 years, plummets. And so this is truly a very prognostic test. It is highly predictive for your risk. Now, again, it doesn't mean that it's destiny. It just means that if you find out you have the score and you don't do anything about it, you're at risk for these things. But of course, nobody on this call would do nothing about it. And certainly I counsel my patients to not do nothing about it. Some patients, I guess it matters a little bit where your score is. If it's in that what we call that left main, which is the trunk of the tree, not one of the tiny branches off the tree, but the very trunk of the tree. If the trunk of your tree is diseased, just like in your backyard, if the trunk of the tree is diseased, then the tree is at risk, right? The tree is jeopardized. But if it's just a branch that's broken or a branch that's sick, then it's not as risky. So what else besides heart attack risk can a calcium score, help you with? Well, as I've kind of alluded to, it can really help you decide on whether or not statin therapy is appropriate. And, there's a lot of misgivings out there about statin therapy, but, certainly for high-risk people, it is a life-saving intervention. And we know that based on one very large trial that came out a couple of years ago, if your calcium score was 0, a doctor would have to treat 549 people for 5 years to prevent one event. Well, that's just not very cost effective. So you're putting 549 people on a statin for 5 years, and you're just going to prevent one event, right? If the calcium score is 0. So this is why we say, if your calcium score is 0, you probably don't need a statin. Of course, if your calcium score is not 0, if it was 1 to 100, you'd only have to treat 94 people for 5 years. That's still a lot of people, but you can see that it's a much more kind of cost-effective approach, so to speak. And then if your score is greater than 100, you only have to treat 24 people. So again, this is a lot of people in my practice, frankly, that have scores greater than 100. And I'm saying, listen, we don't have to treat a lot of people to prevent one event. High-risk scores need aggressive therapy. And so this is where calcium scores can really tell you as an individual and tell doctors whether or not it's appropriate to treat with statins or whether you need to treat with statins. Similarly, another trial called the HOPE-3 trial basically had kind of similar numbers. The bottom line was, again, what we call a number needed to treat. That's that 50 people needed to be treated to prevent one event if your calcium score is greater than 100. And that's typically thought of as a very reasonable number of people to treat if you can prevent a heart attack. And this is just a different pictorial way of saying if your calcium score is 0, that's this box here. Whether you're on a statin or not, you basically have the same outcome. If your calcium score was 1 to 100, there was some benefit for being on a statin, but the benefit, you saw a lot of benefit for being on a statin between, a lot of difference in outcomes for being on statin versus non-statin if your score was very high. Greater than 100, and this is greater than 400. You see a significant difference. And of course, the event rate is higher in general, even if you're on a statin, because these are really the highest risk patients. We know that statins decrease overall plaque and the soft plaque. They are very good at melting away soft plaque. Yes, I said it. Statins are very good at melting away soft plaque. They do something we call delipidating plaque, which makes them less inflammatory and less liable to rupture. And they actually, in some ways, actually promote hardening of the plaque, which you say, well, gee, doc, isn't that a bad thing? And in this setting, it's actually good because it stabilizes the plaque and makes it less likely to rupture and then cause a heart attack. All right, well, besides statins, what else? Well, how about aspirin therapy? There was a lot of hullabaloo about maybe 2 months ago, 3 months ago, about, oh my God, should I be taking an aspirin? Because there was an announcement made by something called the USPSTF, the United States Preventive Services Task Force, that came out and said that most people out there taking an aspirin probably don't need it. And that's true. Low risk people who are taking an aspirin just because they think it'll stop a heart attack at the age of 65 or something like that, most people are not getting a significant enough benefit. But, calcium scores can actually help us determine who would benefit from being on an aspirin. And as you could predict, what I'm going to say is that patients with a calcium score of 0 do not need to be on an aspirin. In fact, they're more likely to be harmed by the aspirin in terms of causing a bleeding ulcer than be helped. So what we call the number needed to harm, NNH, the number needed to harm is higher than the number needed to treat. On the other hand, If your calcium score is greater than greater than 100, then you are likely to derive some net benefit from being on an aspirin. So if your calcium score is greater than 100, you'd benefit. Even if you've never had a heart attack, even if you don't have diabetes, you're likely to benefit in that situation. So calcium scores can be really good at determining who could be on an aspirin and who should be on an aspirin. And this is, again, just another way of saying it. Basically, with the blue and the orange columns in each of these categories being calcium scores of 0 or in the blue and 1 to 100 in the orange. And basically, if you have a score under 100, your number needed to harm was higher than this line of cutoff. And so that meant that you would have more harm from being on an aspirin than benefit. On the other hand, the higher your score went, you went under this line of identity, this line of harm, and you got net benefit from being on an aspirin. And again, regardless of your baseline risk, the calcium score identified people who benefited from being on an aspirin versus who are theoretically going to be harmed by being on an aspirin. Okay, well, what about blood pressure treatment, right? Very similarly, patients with what we call what we used to call stage 1 hypertension. So that's a blood pressure, a systolic of greater than from 130 to 139 or diastolic from 80 to 89. Medical treatment recommended only if you have heart disease already, or if your calculated risk by these calculators is greater than 10%. But what has been seen in research studies is, once again, if your calcium score is 0, it's not urgent to treat stage 1 high blood pressure with medications. But once again, if the calcium score is greater than 100, I keep saying it, sorry, calcium score greater than 100, you should think about, even if your blood pressure is quote unquote borderline, there's probably benefit. And certainly if your calcium score is greater than 220, that puts you into a higher risk category where there is clear benefit of treating blood pressure aggressively. And similarly with diabetes, patients, depending on diabetes duration, and again, worsening calcium score did worse, and could be, this kind of stratification could be used to identify who needs aggressive treatment and who does not. So finishing up, there are some questions we get. Well, gee, doc, I had a calcium score, 2 years ago. And ever since then, I went on a plant-based diet. Should I get a calcium score again? And the answer is, if your score, it a little bit depends on your score and the time since your last test. But in a nutshell, this is trying to show that patients with a calcium score of 0 had a very low event rate up to about 5 years. And beyond 5 years, the majority of people continued to have a 0 score with a very low event rate. But now about almost 1/3 of patients transitions from a 0 score to a positive score and had a higher event rate. So it's reasonable, if you have a 0 score in the past, to repeat it 5 years later and reassess. And if you still have a 0 score, again, you're doing well. If you no longer have a 0 score, it doesn't mean you're going to die. It just means that we now have to treat more aggressively. And this is looking at it in a different way, that basically the transition from a 0 score to a non-0 score was at about 3.4 years. If you had diabetes, depending on ethnicity, also it changed. It was mostly around 5 years was the transition. And again, depending on the score you had to begin with, how much more quickly it would go up. And so what I typically tell patients is to aim for, for 5 years. If your score was either 0 or very low, I think it's reasonable to repeat it in somewhere between 3 and 5 years. And if it's going up rapidly, then obviously we need to assess what we're doing and try to, figure out what we need to change. Now, again, if you're eating a plant-based diet and you have a 0 score and you're exercising, the odds of you going from a 0 score to a non-0 score are truly remote. And as I said, less than 10% of people, I didn't say this, but less than 10% of people with 0 score developed a high score over 10 years. They may have become positive, but they were unlikely to develop a very high score. And so again, a 0 score just portends a very favorable prognosis overall. And as I keep saying, depending on your age, it's kind of like winning the lottery. At young ages, it's still reasonable. I do have some 30-year-olds that have had, unfortunately, positive calcium scores, and of course, we're treating them aggressively. They have bad kind of family histories. But overall, I typically recommend waiting until 40 to 45 years old before you get before you get a score. We can skip through this a little bit. And then, one question sometimes comes up is, well, gee, doc, most medical research has only been done in populations of white men. If I'm not a white man, does this even apply to me? Is it predictive for me? And the answer is, fortunately, yes. This is still, first of all, that is a problem. That is truly a problem with a lot of medical research. And hopefully, people are working on changing that over time and being more inclusive in the studies, in the populations being studied. But specifically with calcium scores, it has been studied in a range of ethnicities, in a range of ages, and therefore, and it has been shown to be predictive with different ethnicities, sex, and ages. So if again, just to give some examples, this lady had a very worrisome family history, but her cholesterol numbers weren't that terrible. And you could predict that she had, because you're listening to my talk, that I was going to give you an example of a similar patient that had a very low calcium score, but at her age, it put her in the 92nd percentile. And she had it in that big blood vessel down the front wall of her heart. And so we need to try to, aggressively reduce her risk factors. This other patient had no hardening whatsoever, none. And so therefore we were able to just, with this patient, give lifestyle advice, counseling, dietary improvements, plant-based diet, exercise, that kind of stuff. Even though she was borderline diabetic and borderline hypertensive and her cholesterol numbers weren't great, this is a lady that really would benefit from lifestyle alone and would not benefit from being put on cholesterol medication. And then this guy, the smoker, well, you got to convince him to quit smoking. And he has a lot of plaque in the big blood vessel down the front wall. That's the widowmaker. His score is 411. He's high risk. And we use that information to help convince him of the need to quit smoking and motivate him to quit smoking. So who should get one? Certainly anybody who has risk factors but is reluctant to initiate a statin. I think it's very reasonable to get one of these to see if you would benefit or not. If somebody's had side effects to a statin and they're worried about restarting it, again, I think it's reasonable to get one of these scans and see if you really did need the medicine in the first place. Really, anybody who's questioning medication, bottom line, I think it's reasonable to get one. And that allows us to risk stratify whether you truly need medication or not. Now, some people say, well, gee, doc, how many of these things do I have to get? It is a CAT scan. Doesn't that involve radiation? Well, as I said in the beginning, this is a very low radiation CAT scan. It's about the same amount of radiation as a 3D mammogram, which is, currently all the rage about the best way to do mammograms. It's about the old-fashioned mammograms. It's about twice the amount of radiation as an old-fashioned mammogram. And again, we're recommending, yearly mammograms for half the population of the country, basically. So this is a very reasonable and very low amount of radiation. We are exposed to radiation just in general, living on the surface of the earth. And so we get about 3, what are called millisieverts of radiation exposure just being alive each year on the planet. And so this is 1/3 of that in a scan right here. So again, I'm not trying to make light of it. We definitely don't want to be doing CAT scans on a yearly basis to large populations of people. But certainly one calcium score is not gonna make or break things. And it's only $49, which is pretty wonderful. Years ago it was more. Prices come down. It really takes no time to do. And so I think all the institutions in this area offer it for the same price. And you don't even need a doctor to order it. You can just call up and say you want one of these. So just in conclusion, we have not made great progress in the 21st century in preventing coronary disease and really even treating stable coronary disease. We've made tons of progress in treating acute heart attacks. But in preventing heart disease, we have just not done enough. And so it's certainly my recommendation to think about doing this to better assess your heart attack risk. And that's it.
Outstanding presentation. Thank you so much, Dr. Liberman.